Good morning, viewers. Thank you for joining us for another wonderful AHA live event, live connection event, rather. Thank you for joining us this beautiful early morning. Kate, how are you this morning?
I'm doing great. I'm so excited to be here. And I'm really excited about this first installment that we're doing of the Coffee and Case Studies series that we're hoping we're going to be able to do with PTs and SLPs as well. But this is really the first live connection that we've ever done that's discipline specific. And while this is specifically tailored to OTs and the clients that they see, I'm excited to talk about all of the things that we're going to talk about today because I know a lot of my kiddos while I'm working on my speech and language goals, also have some things that they're working on with occupational therapists. So I'm very, very excited.
Yeah, it's going to be a really good one. I'm hoping that we're going to get some good viewer involvement, good questions. We've got some videos to show you guys today, so should be a really good one. Before we jump right into it, though, just wanted to review a couple things. Don't forget, as a reminder, as a member of AHA, you save $175 off of educational courses through MedBridge. I definitely advise you take advantage of that. It's wonderful. They've got some wonderful courses to offer for all of the disciplines. You also, as a member, have free access to over, I think it's 1,500 research journals through Science Direct. That is normally a database that you would have to pay for. So, and we are offering it to you free. So definitely check that out if you're a member, or if you're not a member, join AHA and take advantage of those member benefits.
And we also wanted to mention while we had everybody on today that we do have some very exciting upcoming courses. So to cater to some of our more international members, we've added some courses at earlier times in the day. So we're going to be having courses at the end of June, June 22nd and 23rd, starting at 5 a.m. Mountain Time. That will be definitely more accessible to individuals who live in countries and time zones that it's just not possible to attend courses in the middle of the night. We also have a Part 1B webinar coming up in September that will be presented at the same time on September 15th and 16th. They're both taught by Mary Helene and Sarah. They're going to be wonderful courses. And we hope that if those times work for you, that you'll sign up.
All
All
right.
right.
Well, I think it's time to just jump right into it. I have the pleasure of introducing our first lady that's going to join us this morning. Her name is Lauren Januith. Lauren is an occupational therapist and owner of Brandywine Occupational Therapy, LLC in Wilmington, Delaware. Her practice offers school-based therapy and outpatient therapy incorporating horses. She obtained her Master of Occupational Therapy from the University of St. Augustine for Health Sciences. In 2012, she became a board-certified clinical specialist in hippotherapy. She has served on the board of the Delaware Occupational Therapy Association and the Florida Occupational Therapy Association. She is a past president of the American Hippotherapy Association and is a member of AHA's Ethics, Advocacy, and Reimbursement Committee, Board Development Committee, and Website Task Force. She is a lifelong equestrian. When not at the barn, she enjoys adventures with her family and friends. Welcome, Lauren.
Hello.
We're so happy to have you with us today.
I'm so excited to be here. Thank you.
And I have the honor of introducing our second presenter, Gina Taylor. So, Gina Taylor, MSOTRL HPCS, is a New Jersey licensed OT. She received her master's degree in occupational therapy from Philadelphia University and a Bachelor of Science in Equine Studies from Everett University. She is certified in sensory integration, DIR floor time, infant massage, and is a board certified hippotherapy clinical specialist or HPCS. Gina continues to expand her knowledge and the knowledge of other therapists about hippotherapy used as a treatment strategy through fieldwork, student supervision, national conference presentations, and her involvement with the American Hippotherapy Association as a faculty member, past board member, and previous education committee chairperson. Gina has a private practice providing occupational therapy services, as well as workshops and consultation for those interested in equine assisted activities and therapy. Welcome, Gina. We're so excited for you to be here.
Good morning, everyone.
So I just wanted to mention that unfortunately Heather was unable to join us this morning. She's not feeling well, and while we're going to miss her, we know the conversation is going to be wonderful. We're very excited to talk about the case studies that we have. And if anyone has any questions, you can please interact with us from the chat through Facebook, or you can message us on YouTube. You can send us an email to the new AHA Live Connection email, and we'd be really happy to get back to you. All right.
So let's just jump right into our first case study. I'm going to give everybody kind of here some background information. Lauren and Gina, I know you've had time to kind of review this case in a little bit more detail, but I'm going to give just a very kind of brief synopsis for our viewers, just so they have kind of a picture in their head. And I also have some little videos that I can show. And then we're going to jump down into our conversation. So our first case study is an absolutely adorable little boy named Sagan. He is very social 3-year-old boy diagnosed with spasmus notans amblyopia, autism spectrum disorder, cortical visual impairment, global developmental delays, and language processing deficits. He tested below average in the domains of grasping and visual motor integration on the Peabody developmental motor scales. He has a very difficult time with visual attention, visual motor coordination, sitting or standing stationary, impulse control, and he presents with language processing deficits. The family's main concerns are hand-eye coordination, fine motor control, attention, and utensil use. So let me start us off with just showing a brief little video clip. And I think one of the things that this very short clip really captures about this little boy is his poor visual attention and hand-eye coordination. I'm not an OT, so feel free to point out all the other things that you notice in this video, but those are just the things that I, as an SLP, kind of noticed.
What color do you want?
Make it top.
Do you want blue or green?
This one.
Green. Okay, can you take the top off? Okay, Sagan, can you draw?
Yes.
Sagan, draw.
No.
What a cutie.
Absolutely adorable. I love him to death. So yeah, let's start off the conversation with just some, I realize it's a very brief video, but what are some of the clinical observations that you guys were able to make about him and just in that one short clip?
Lauren, you want to go first?
Yeah, sure. So definitely, I'm not quite sure he understood the taking off the tops, and he just sat there and twisted and twisted and twisted. And we know that that's a skill that he has because he's able to unscrew tops based on the report that I got. And I just to me, his greatest challenge is that visual attention, because his eyes and his head were just wandering all over the place. There was no focus on the task at hand, include when he was asked to take the top off, when he was asked to pick a pen or a marker, when he was asked to draw on the board. I feel like we could use equine movement to help with his attention. We could, I just think that something that we talk about a little bit is just that activation in the trunk and how that positively affects attention. And so I would love to see him after he was on a horse for a few minutes.
Yeah, and I do have another little short clip I'll kind of show you, show sort of the same thing. But before I do that, Gina, what's your take?
Yeah, so I think when we look at his performance on this relatively simple task, take a marker down, open it up, and draw something on the board, at 3 years, 8 months, that most kids would not struggle with this task. Most kids in that age range would understand the task innately, they to go ahead and they'd probably be super. I think with him, we see kind of a lot of areas that he's struggling in, and there's no flow in his lesion. He does seem somewhat motivated to get to the board, but he just the steps away. There's a lot of impairment in that kind of sequencing his actions. I think attention, like Lauren said, is a big factor to that. So I think as he gets some more sensory input and some more motor input, it would be interesting to see how his performance improves and then how we can integrate those two things together, because I think that will improve his functional performance when he's outside of our treatment session, because he's really stressed that should be innately motivating for him.
Yeah, I totally agree. Let me show this other brief video clip just to give a little bit more information. Wrong kid.
All in.
Let's do that. Then
Keep going.
I take it in my hand.
Yeah, put them in.
My nose. My nose.
What are you doing?
I put that away.
Okay.
There's water.
Say again. Good job.
What's that on the white one?
It is. You have to look.
I'm gonna turn it. There's another one.
Yeah, put it in.
There's no. Oh, I dropped it. I'm sorry I did that. Okay. The light in the
I can't. I'm dying over this little guy. He's so cute. He is so cute. But what a different video.
Yeah, and so I just have to throw this out as his treating SLP. So one of the things that I'm working on with him is various aspects of language processing. And because SLPs don't get a really good educational background in visual motor, I have had to learn a lot about it from co-treating with his OT, because we can't incorporate things like static photos, very two-dimensional things, even testing. A lot of SLPs out there know that testing involves a lot of two-dimensional picture easels, and I couldn't go that route because visually he just could not focus on anything two-dimensional. So even in our treatment, I've been trying to incorporate three-dimensional objects to talk about, and I can't get him to look at that, which as an SLP can be a little bit frustrating. And the OT is really helping with that aspect. So I've learned a lot as an SLP, and I'm still learning about how much that visual attention, visual motor piece is affecting all aspects of his functioning, not necessarily just his manipulation of things with his hands.
Yeah, listening to you talk about that, it just makes me think about how fortunate I feel to be able to use the tool that we use. That's all four of us, right? Even as we're SLPs and your OTs, but it really does force that whole person treatment, right? And it's very easy to sit a kid down at a table. Not that it's very easy. Speech therapy is hard no matter how you're doing it, but it's easy to sit down at a table and focus on someone's mouth and say, okay, this is what I'm working on. And you're looking at just this part, right? But to consider all of those extra pieces, like Nita was just talking about, with his actual ability, like his visual impairment clearly significantly impacts his ability to interact using his communication status, right?
I'd like to make a comment. So something that I learned in OT school was that proximal stability promotes distal mobility. And so when I talk about that with students or when I utilize it in my practice, I'm thinking about how this proximal stability is going to promote better gross motor skills, better fine motor skills, better oral motor skills, and even better visual motor skills. And so I think he's such an excellent candidate for the use of equine movement. And I just am thinking about all the different things that I would do. But he's so adorable, I would love to work on crossing visual midline and just promoting more trunk stability in him, I think would help him a lot. I just saw kind of a lot of trimmer and just how he uses both of his hands. And, I just think he's such a great kid. He would be a great kid to work with.
Yeah, so I'm glad you brought that up. Let's dive into that piece. And Gina, I'll let you go first, but let's talk about what are some of the considerations that I realize this is, just a piece of the picture you're getting of them, but based on what you've seen, what are some of the considerations with regards to equine movement? What might you be looking for from a sensory aspect? What are your thoughts?
So I think he shows some interesting adaptive behavior in that he knows his visual system doesn't function. And so he's like, well, that's not working really well. We know there's a physiological reason why he doesn't see well. There may also be a processing, a brain neurological component why he doesn't quote unquote well. And so he's like, you know what, that system doesn't work real well for me. I'm going to move on. And I think it was really telling in the photo. I was like, look at what you're doing. And he's like, why am I going to look when it's like, it's not going to help me? And so I think, from a strengths-based approach from him coming in from the other systems that are stronger for him would be a really good way to kind of help promote some of those things. And as Lauren was saying, when we really activate the trunk, we're going to improve those fine motor skills throughout the body, whether that's the hands, eyes, or mouth. And I think from him, that approach I would be taking is, kind of thinking back to our treatment principles part 1, where we really look at those practical applications of before we work on. I think that's kind of where he's centered on getting some input through the hands, through the shoulders. You're going to kind of see more stability coming up into the mouth, into the jaw, more stability in his visual. My theoretical base of where I would go with this kid. How about you, Lauren?
Yeah, definitely. I always like to start with just pure movement, and then I go into school figures, and then once I've done school figures and probably pace changes, then I do kind of look at position changes. And I completely agree with, we could put him backwards and have him weight bearing on his upper extremity, maybe even putting him in quadruped and having the horse walk forward, I think would be a great way to go. And then just talking about, I love what you're saying about the strength-based approach. Probably off the horse, I would do some stereognosis activities, and then have him maybe from naming without using his vision, like maybe working on matching, things like that. There's just so many things to do with this little guy.
Okay, Lauren. So as an SLP, could you explain stereognosis for me? Because that was
Thank you.
right over my head.
Stereognosis.
I'm like, yes, stereognosis, definitely. That's it.
Stereognosis is the tactile knowledge of an object. So when you stick your hands in your pocket and you look for your keys versus a quarter in your pocket, you're using your sense of stereognosis or your skill of stereognosis.
You know what? I love that you just, as a treating SLP, you just gave me a great treatment idea from an SLP standpoint. So I'm gonna clock that one away.
Awesome. I bet you've got some stereognosis tools at your clinic that you can use.
Many. Yeah.
Yeah, it actually just got me thinking about what you were saying with asking him to visually describe things, and if he was using his hands, how cool, right?
Mm-hmm. Mm-hmm.
And that's actually one of his treatment goals for as an SLP is to use his language to be able to describe objects both present and not present. And that is a challenging task for him, both present objects and not present. And how wonderful to be able to tie in those two OT and speech realms together. I love it.
This is really the beauty of working with other providers from different disciplines, right? Because Lauren, when you said that, look at how Nita's eyes lit up right away. And she was like, oh, I know exactly what I'm going to do this week.
It's wonderful. Well, and I've always wondered about that connection between that forward feed visual input using the equine movement with these kiddos who have these complex visual disorders. And something that, again, as an SLP, you don't get a lot of background on. I'm learning more and more about it. But I definitely think that that is a tool that could be very, very useful for these kiddos.
And I would think this kid is going to struggle a lot with kind of a dual task in managing his body and his postural stability with a visual task right now, because there's a lot of nice gaze stabilization tasks that you can do with equine movement. As Lauren was mentioning, the school figures, if you have a central visual object for them to fixate on, and then the horse is tracking around, that's a great gaze stabilization task. I don't think he's obviously in the whole minute of video that we've seen, I think that would really be a struggle for him.
Oh, I agree. I definitely agree. But maybe something very long-term down the road, very long-term could be.
So I probably wouldn't do this with him, but I have in the past with a more organized client, put objects, in a stereognosis box behind their back and have the horse walk forward, then come to an abrupt stop, have them reach behind their back, name an object, and then have that's how, but I would not do that with that child. I think I completely agree with what Gina said. I would do my stereognosis activity off the horse, probably maybe at your desk.
All right. So I have a question. So I'm hearing, you got my wheels turning on something I say to families all the time, that we don't want to make a child do too many hard things at the same time. Right. So just thinking about how this might look during an actual treatment session with this child. Is this a peanut that you might use equine movement with and then work on goals, not really work on goals while you're using equine movement?
So I would think his goals will be incorporated in. Oh, go ahead.
Go ahead, Gina, and then I have something to say about that. Go ahead.
Yeah, I think our use of equine movement is always addressing the goals. It might be addressing some of those core foundational skills. We might be using it in OT terms as a preparatory, I think, to get his arousal, attention, and core activated to then work on the functional activities. In OT, we're often going to go from preparatory activity to functional activity to occupation-based. And so I think he's a kid that does need that preparatory activity. In a clinic, I could use a swing, I could use a ball, I could use, a ball pit, something to get that same result. I can get it quicker on the horse, and I can get it through more sensory systems on the horse. But Lauren, you're nodding your head. So
yeah.
Yes,
that's exactly what I was going to say.
Kind of thinking the same.
Yeah, I think that equine movement is, sometimes I think of it as a preparatory activity, but I also think of it as it's so engaging. And another thing that I learned in OT school 20 years ago was that you can't have a great OT session without engagement. Engagement is the first thing. And you walk into a barn and you've got this engaging, occupation-rich environment just right off the bat. So, yay us.
Okay. I love it. So
I think we're about ready to move on to our second case study.
Yeah.
All right. So let me talk a little bit about this peanut, and then we'll show a video clip and get right back into it. So next up, we have Sterling, right, Nita? That's our next peanut. Okay. So Sterling is an outgoing 7-year-old boy with no medical diagnosis. He's received a preliminary diagnosis of autism when he was younger, which has been revoked. On the bot, Sterling tested within average limits for fine motor precision, fine motor integration, and manual dexterity. He tested below average in upper limb coordination and manual coordination. Sterling is reported to struggle with visual attention and ocular motor control, specifically with tracking moving objects. So let's check this little guy out.
I'm gonna see you guys do it 5 times.
That one was a high shot. And you know why I like the high shot? Come on, come here. You got little Rudolph nose. What it is like Rudolph's. We're not passing the Mazetta.
I love the Rudolph nose comment. I agree.
All right. So what are some of the observations you guys can make just from that short little video?
Think with him,
I'll talk
we're
a lot.
definitely not seeing, age typical scat, given his kind of history where he had a diagnosis and it was revoked, like he's not presenting in a typical way where it's like, okay, we can put him in this box or we can put him here. But yet when you look at him, you're like, okay, yeah, there's definitely deficits because he doesn't look like a typical 7-year-old kid. And I think getting help for those kids is especially important because they don't get picked up. They don't get a lot of the other supports. And, if they do kind of come into a more traditional clinical setting, worksheets aren't going to work well probably with this type of kid. So I think, we are already kind of setting ourselves up for success for a kid like this and a family, supporting the family with their needs, because it sounds like they've had probably a little bit of a challenging path just given the history for this kiddo.
Yeah, absolutely.
definitely
And
see that.
I totally agree with that comment you made. And I'm pretty sure that was, from what I read just from a lot of his documentation notes, one of the main concerns that his mother had was that he does not qualify for services in the schools because their benchmarks are, set at a certain standard. And what he struggles with definitely affect him in the schools. And so his mom, came to us and was like, help. And we're able to identify those needs. Let me show another brief little clip of him here.
No. And hand is the trickiest place ever.
Nita, can I ask a question?
Yes.
Was he tasked with doing that with his left hand?
That's a great question. I don't exactly know the answer to that.
Yeah,
I would say no. I would say my guess would be just no, that they just asked him to, put the tokens in the piggy bank and that's what you got.
All right. Well, I can't wait to hear what our OTs think about it.
So, Kate, I bet he's probably left-handed. And he also demonstrated just in that little clip what I would think is probably really poor bilateral integration. But I think when I think back to the other clip, I have concerns for his balance. He has such a wide base, and he is moving all over the place. He really can't stand. He really can't control himself. Once again, I think he's another excellent candidate for the organized, symmetrical, rhythmic, reciprocal equine movement. So once again, he would be another really fun kid to look at. And I'd also like to say, Gina kept saying he doesn't look like a typical 7-year-old. He's almost 8. and he really doesn't look like a typical 8-year-old. And my concern for him in school would be that if he doesn't qualify for services now, he's probably going to be one of those kids that qualify in 5th or 6th grade. And then, there's this huge gap. And so, thank goodness his family brought him to you guys.
Yeah.
Yeah. One of our viewers actually just commented on the way he's moving and his hypotonicity. So they commented on the movement using a wide base of support and then some hypotonicity. So maybe we could talk a little bit. Yeah, there it is. Thank you, Martha, for commenting with your observations. So I'd love to hear you guys talk a little bit about that, and then maybe how you'd use equine movement to support him in working toward his goals.
Yeah, I think we see in that second clip where he's putting the coins in, he has the ability to pick them up, to transfer them through his hand. But I think when we see with that hand holding back, that as a point of stability, and he's not integrating both sides together. So we know that he is seeking stability throughout his movements, whether it was more the gross motor clip or the fine motor clip. He's using that wide base of support as a place to be stable. And so I think when we think about our horse selection, that might be an important place to start for him. Are we going to start where he's comfortable, which is a more wide base of support? Probably, I would think a lot of linear types of movements. I really kind of want him moving this way. I want to bring his hands here. He's one hand out to the side, bringing him kind of central again, as I was saying about being organized. I think that would help to organize him. So I would be really starting, Martha said, with that wide base of support where he is comfortable, and then helping. He's spread thin, be interesting to obviously using the tone and the strength that he does have.
I agree with that. And, I would like to just see how he tolerates the equine movement. And like you said, lots of linear. Maybe I would start with a wide base, and that linear, and definitely the linear movement. Maybe I would, probably, just because I think that, like you were saying, Gina, that's where he's comfortable at. And I think just when we introduce equine movement, it can be such a novel experience for our clients that we do want to kind of go easy on them, and then kind of gauge how they're tolerating it. And then, maybe we would decrease the base of support, possibly increase the dynamic movement, introduce more school figures, and positioning. Once again, he would benefit from so much, especially on that dynamic base, and just having to really keep himself together and keep him. That would be so amazing for him. I feel.
It sounds like it. It sounds like it. And I really hope. No, I'm sorry, Gina, go ahead.
I think given his age and his ability level, progression, as Lauren was hinting at, is going to be really important. I see with a lot of clinicians, they are selecting horse tack equipment, kind of a plan of care of how they're going to integrate equine movement. And then they're sticking with it for, 8-10 weeks. And I don't think this is a kid that I would want to do that with. This is a kid where I would want to start where he's comfortable. I'd want to build some rapport. But because of his skill set and his age, I would want to see a much quicker challenge. I really want to be focused on that and making sure that he's not kind of getting a little in his comfort zone or a rut.
Yeah, and I think this kind of goes back to with what we were talking about with the last little peanut we saw, that it's very clear when you talk about using equine movement with this client that you're really working on goals while you're using equine movement. It is a treatment tool that's being used directly to address goals, like you were both saying before. We just got a really nice question in the Facebook chat. So whoever wants to answer it, please feel free. But Martha just asked, can you explain what you mean by linear movement and using linear movement to support him?
Sure, Martha. Um, Linear movement. So we're talking long straight lines, where we're really working in a forward backward plane for him, and that's where I would want to start with, kind of because he's already in this more lateral plane where he has this wide base of support. He's got an arm hanging out to the side. I would want to really be moving this way with the body. And so, from our equine movement perspective, we would be more long straight lines, transitions. Those are going to really work on more of this anterior posterior linear component, not so much lateral. I'm not. He already does that. I don't really want to emphasize that, and I don't think he's quite to the rotational component yet.
So you're thinking not only would you use long straight lines with movement, but you'd also choose a horse with anterior posterior movement as their primary. Yes.
At least to start with. Again, he's one I'm thinking progression is going to be quick, but yeah, just because I want to see him move a little bit in that plane. I feel like he's missing that in what I'm seeing in those two little.
That's great. Wonderful. All right. If we don't have any more other thoughts or questions on this little guy, Anita, do you think we should move on to the next one?
Sure. And so I'll read off. I'm going to try not to bore everyone with me talking too much, but I'm going to read off this next case study. Unfortunately, for various reasons, we were unable to obtain a video of him. So as I kind of give a verbal description, I just want our viewers and our lovely ladies here to just kind of paint a picture in their minds. And then if you have any questions, I will do my best to answer them for you. This is not a child that I treat, but I am fairly familiar with him just from general interactions in our facility. So our next little guy is Greg. He's a very sweet 8-year-old boy with some interesting diagnoses. He has Dandy Walker malformation and agenesis of the corpus callosum. He also presents with schizencephaly, optic nerve hypoplasia, about 50% in each eye, and hydrocephalus. He's able to sit at a table in a chair with a back with no additional support and reach forward outside of his base of support with effort. He's able to reach to each side but does not extend outside his base of support. He spontaneously crosses midline when required during an activity. He enjoys clapping and is able to hold an object with both hands. He struggles with alternating tapping patterns with his hands and does not frequently spontaneously pass an object between his hands. He wears glasses but does not tolerate them well. He does not visually track items well, and he's unable to place any forms in their matching hole. So as an SLP, I'm guessing that would be like a shape sorter. Is kind of what I picture. He can push his arms and legs through clothing, and he attempts to brush his hair and teeth with support. He participates in hand washing, but continues to need assistance. He can open his thermos bottle with a cap consistently, and he can bring a loaded fork to his mouth, but he is unable to poke the food with a fork. He does not enjoy using a spoon. He frequently gets upset when multiple adults are talking near him, and he will go from laughing to crying very quickly. So, any thoughts?
I see a ton of goals that we can work on almost immediately. So because he's got hydrocephalus and a shunt, I think we have to be really careful with him. And then also, I think just he seems extra sensitive. And so if I were going to put him on a horse, and I probably would try more carefully, I would probably choose a horse that's going to have maybe lower amplitude movement and just very easy on the sensory, easier on the sensory systems than, something that has a lot more dynamic movement. Because I feel like he is a sensory child. I feel like equine movement would be used more as preparatory activity, but I do think that there's a lot we could do with him on the horse at midline, and just having that midline awareness and bringing his hands to midline and crossing midline, all of that stuff. I think that we could use the horse in so many ways for this child, but once again, cautiously, because of his condition.
So can you elaborate on that a little bit, Lauren, for our viewers, what you mean by you would be a little bit more careful because of the hydrocephalus in the shunt?
So he has a shunt. So we would have to, number one, look at where his shunt placement is as far as helmets are concerned. And then we would have to also, Nita, I don't remember if you said that he has seizure activity, but in the, he has had a history of seizure activity, but he hasn't had one in many years. So that's another thing that we have to really monitor. We don't, equine movement is so dynamic. Even when you've got a small pony with lower amplitude movement, it's still very dynamic. And so we have to just be very cautious. I mean, I think that this could, equine movement, he could benefit from it, but I think we just have to approach it with a lot of caution, many eyes, and maybe a lower dose of equine movement and more stuff on the ground for him.
So when you say a lower dose, you mean you would use it for a shorter period of time within your treatment session?
Yes, at least initially. And then once again, we're talking about progression in our our session to session treatment plans change. And so if he's tolerating 10 minutes, and maybe next time we're going to do 15 minutes, maybe we'll do more, it'll just be more of a progression. We'll add school figures, eventually maybe position changes, but it's also going to be like, how much can his sensory systems tolerate? We don't want to overwhelm him. And it is possible in this environment with this amazingly powerful treatment tool.
Yeah, I'm happy you said that about the amount of time, because I think a lot of times, I mean, I know at our practice, we see kids for 30 to 45 minutes, typically about 45 minutes. So I think as a person who doesn't use equine movement, or as an individual who's maybe seeking out speech and language, OT or PT, utilizing this treatment tool, 10 minutes doesn't really sound like a very long time. But for a kid like this, that's an incredible amount of time with an enormous number of neuromotor inputs, right? In a treatment session. So in just 10 minutes. So I'm really happy that you brought that point up. I feel like it's a very important one for this little guy.
Gina, do you have any thoughts?
Yeah, I think with this particular case study, because there are some medical concerns, that history of seizures, he's 8 right now. I know that as we approach puberty, the chances of having some recurrence of seizures is going to probably go up for him, with the shunt and his kind of functional capacity with the agenesis of the corpus callosum. What are those family goals? He's going to need continued support. So what's going to be the most functional areas that we can work on, given the fact that he's going to need continue? What can we do? Really, in this case, when I think about it, I think about almost caregiver assistance, level of assistance. I like to use the PD-CAT, which really determines how much assistance the parent or caregiver is providing. So with this case, I would be really taking an approach of where can we reduce the caregiver assistance by helping him be stronger, more coordinated, be able to do some self-care tasks by himself. And I think through incorporate, we can go ahead and work on some of those components, so that way, as he gets older, as he gets probably bigger, helps his family care for him. And I think, again, kind of taking in his whole clinical picture is really important in the equine movement setting, because we do have some of these medical components. Then we add on to that this really sensitive sensory system, as Lauren was talking about, and that it's going to be a challenge for him. And one of those cases where if we can widen that window of regulation, we can help kind of the whole family, right? Because we can help him be more regulated. We can get him to a point where he can take more of the environment outside of horses, outside of the barn, outside of my OT session. You know, he can talk more of going somewhere with his family, because I would guess that that's probably a challenge for him.
Yeah,
Yeah,
and
it sounds like it.
I love what you said about that point of reducing the need for family support. And I would be curious to know what your experiences with this, with, you know, other cases where do you see a lot of that where initially a child requires a lot of support from the family because of motor and or sensory limitations, but then as that individual gets older and probably gets to a point where they actually have some of those foundational skills where they could be more independent, however, a routine has now been established where that parent just they've been doing it for years, and the parent can just, it's almost faster and easier for the parent to just go ahead and brush the kiddo's teeth or brush the kiddo's hair or get the kiddo dressed. And you almost see, I hate to use the term enablement, but for lack of a better word, you almost see this unintentional enablement from the parents. Do you guys see that a lot?
Lauren, you want to
I
jump first?
do.
Sure. Yep, go ahead.
Yeah, sure, I do. And parent coaching and caregiver coaching is so important, especially for kiddos like this. And so, you know, I tend to kind of remind the parents that we're here to increase their independence. And also I like to talk to them about their schedules. And I realize getting ready for school may not be the time to work on dressing skills, but the weekend is a great time to, when you're not in a rush. So I try and feel out the family schedule and then kind of determine, well, why don't you try it on this day when you're, you know, you don't have to be somewhere at 7 a.m. and you're not getting the other kids ready and you're not dressing for work and preparing for your speech or whatever it is that you're doing. And just trying, you know, fitting their work at home, which I always like to give home activities to work on because that's so important for just for progress. Where do we fit it in their schedule? Did that answer the question?
Yeah.
Yeah, absolutely.
And
Gina, did you have
I
anything
think
to add to
I
that?
think with that, yeah, you know, with a child that is not going to become independent in life skills as they age, what is important to the parent? If brushing their teeth is not important and they can do it faster, great. But when you come to me and you say, you know, my kid's like 89 pounds now and I'm starting to have back pain from transfers, great. Parent is motivated to learn a new way. And I've found, you know, kind of thinking back to a specific case, that really just getting that client to be able to kind of wait for that made such a world of difference to the parent because they couldn't get them up into the car or like minivan. They couldn't get them up into the minivan, and the kid didn't have neither the strength nor the coordination to. And so we worked on a kind of a very simple motor plan. If we think about our transfer from a platform onto the horse, there's a lot of similar components. So it was a step, hands down, and then scoot. And so we could take that from our treatment session and then go practice it with mom at the minivan after, and kind of had this same, and again, you know, being kiddo that not doing it at a cognitive level, not going to work in this case, it was really a learned motor plan. And so we would practice it. We would get a good dose of equine movement. We would kind of practice a similar motor plan in our transfer off, and then we would go practice it getting into the minivan. And that was really going to be the most functional thing for the family.
It really sounds like it. Yeah. We had we have another wonderful question in our chat, and I'm just hoping that one of you guys feels comfortable answering it. So Martha's asking, in the 10 minutes that we're using equine movement of your session, this hypothetical 10 minutes that we talked about, what type of movement from the horse would you be looking for?
The golden question, right?
I can go first, just from the picture in my
Best
mind
answer.
of
It depends.
of this child. So once again, I'm thinking about lower amplitude, probably that linear movement. Once again, I want to keep things simple and monitor their tolerance, and then the progress would be based on the tolerance of that 10 minutes on the horse, and how organized are they when they when they transition off the horse. And because I feel like I would use equine movement as a preparatory activity at this point with the information I have. Gina?
Yeah, I think with this particular client that I have in my head, which may or may not be the same one you have in, is that very careful clinical monitoring to see how he and for me this is a, you know, if we want to break it up quarter by quarter of the arena, is he tolerating it? Do we need to stop and all take a breath? Do we need to give him a 30-second to 90-second pause in it so his sensory systems can go, meaning that kind of coming in the time you're at such a delay, you're going to see kind of the result in the next 3 to 5 minutes. And so with this level of client, with this kind of situation, I need to be on it much quicker because I need to start seeing if we're having this overflow, again, taking a 30-second to 90-second stop to see, are we all caught up? Are we good? Can we keep going? Would be kind of a little bit of that approach. And it was interesting because you said in the case study, that he can reach forward. So he's got a little bit of this. So developmentally, the next thing I would be looking for, yes, exactly, Lauren, the next thing I'd be looking for is this. So starting to challenge him with these lateral types of activities, because I want to kind of take him through that developmental sequence. So in that brief 10 minutes, we've already chunked in a ton of stuff.
Yeah, and I think there's a lot of considerations, right? It's not just how the horse moves, and you both touched on this, but it's not just about how the horse moves, it's about how the horse is built. So we're looking at conformation, we're looking at the type of movement that the horse is providing. Like I hear Lauren talking about amplitude, and my mind automatically goes to vertical displacement when you talk about amplitude, which may not be what you mean, but talking about that anterior posterior movement that Gina was talking about, that this is obviously something that this client has, as opposed to the lateral movement, which maybe is something that would be challenging for this individual, just from my speech brain. I don't have the OT brain. So go ahead, Lauren.
I'd like to also say something, that when I begin with a family, I always let them know that equine movement is part of the plan. It's not the only plan. And there may be times when equine movement is not safe. And so we may not always use the horse. There may be days that we use the horse and not put the client on the horse. There's so many different factors. And I try and really spell that out for my families so that they know that they're coming for occupational therapy and not something else.
That's okay. You put up air quotes, so I know a lot of people listen,
clear
but
expectations.
I know a lot of people listen and don't necessarily watch, but just for those who were listening and not necessarily watching, I think Lauren was going to say horse therapy with air quotes around it.
I didn't want to say it though.
It's okay. I'll say it as long as we say that there were air quotes, because we don't use that. We don't use that term. All right, we have one more little peanut to talk about. So I'm just going to jump right into them. So our next little one's name is Tyson. He's 2 years, 6 months old. He has no medical diagnoses. He does have a sensory-based feeding disorder that's been identified, and he is diagnosed with severe childhood apraxia of speech. So his family reports that Tyson seems to always be on the move and that he tends to roughhouse and loves to climb on furniture. His family shares that Tyson still sleeps with his parents in their bed and that they would like to improve his sleeping routines and habits. Tyson's mother reported that he's having a hard time calming himself and would like to improve this skill. And they also shared that he has a difficult time with toileting and hygiene. So he presents with some severe sensory differences in his tactile and oral systems, which impact his ability to get adequate and varied nutrition. And he does not register tactile sensation, which leads to avoidant behaviors. He does not seek new experiences to fill in these gaps, which also contributes to his feeding difficulties. So again, we don't have a video on this little guy, but I can totally picture this little person.
Well, and I can throw in another little piece of information in. So this is actually this is a case study I submitted. This is an individual that I see in the clinic and came to me for feeding issues in addition to severe childhood apraxia of speech. And I brought the OT in to help me with the feeding issues and had her help identify some of the sensory aspects, because again, as an SLP, sensory is not, we don't get a strong education in that as SLPs, and it's not within our scope of practice to treat necessarily. But I can tell you that I found this kiddo absolutely fascinating because he is a kiddo that, from my perspective, and correct me OTs if I'm interpreting this, wrong, he is a seeker, which to me signifies that he's got low registration. He needs that additional input to kind of know where his body is in space. But in a lot of things that he does, once he seeks out that input, he immediately becomes defensive against it, which to me just like blew my little brain. And we see that a lot in his feeding. So when he goes, he likes crunchy things, but when he goes to eat, a goldfish cracker or something crunchy, he's one and done. And he'll eat one and then that's it. He's done and he doesn't want any more of it. And it's really been a struggle for the family nutritionally because A, he has that sort of presentation when he's actually putting food in his mouth, but then also B, he will not sit stationary. So trying to get him to sit at a table during mealtime is also very difficult. He's always on the move. And so yeah, I would love to hear your guys' thoughts on sort of that sensory presentation of seeking and defensive at the same time.
Yeah, is this what I hear OTs talk about when they say a child has a small window?
Probably.
Yes. Yes.
Probably.
I think of like my ideal client, maybe that's just because I'm living it. I don't know. But interesting to hear about they want to address some sleep issues. I mean, toileting, I think, would maybe be a little bit lower on the priority list right now, given his age and the sensory challenges he's having. But feeding is going to be huge. It's going to impact that apraxia of speech as well. And I think what we're seeing is we're seeing sensory seeking and proprioceptive avoidance and overstimulation in the tactile system. And so he's seeking proprioceptive and possibly vestibular input. I'd have to see him moving to see if it's the vestibular. So maybe his vestibular system is also very oversensitive. And he's trying to use that proprioceptive input. So the movement, the crashing, the jumping, to regulate. And so with him, I'd really be looking at a co-regulation strategy. He, given his developmental age, given his sensory issues, he needs a co-regulator. And whether that's the horse or whether that's his mom or dad or the therapy regulator, he's not going to get there right now developmentally by himself. So that's where I'd be starting. Lauren, where are you going with this boy?
Probably not exactly the same place, but that's exactly what I was thinking, all that proprioceptive input. But once again, we'd have to really monitor what is his reaction to maybe a horse that moves a little, that has that more proprioceptive input. But I'm just thinking about all the different ways that we can add proprioceptive input to his day. with us in therapy, at home with mom, just coming up with different ideas for that, because you can't get too much proprioceptive input. So I feel like that would be where I started. Yeah, that's where I would start.
So we have a question in the chat that we're going to answer here in a second. But before we do, I just wanted to point out another piece of information. So as an SLP, before I was able to bring an OT on to help co-treat this individual, that's kind of where my thought process was going was, all right, let's give this kiddo some more proprioceptive input. It's really going to help with the overall speech aspect as well. And so we put him on a horse that had some real nice concussive footfalls, provided a lot of good proprioceptive input. He tolerated that well. We manipulated the movement to further, provide further proprioceptive input. And he immediately became defensive against it. But then, as soon as we then backed off of that, he asked for more. So, and I was like, are you sure? And so then he was like, absolutely. He has an AAC device. He was like, more. So then we again manipulated the movement again to provide him that. And again, he became defensive and then again asked for more. And I was just like, okay, wait a minute. You want more, but you don't like it. I don't understand what's going on here.
Well, I think that's really, really interesting that, I think that's, our classic toddler is, mommy do this. No, don't do that, mommy. No. And you're like, cut it. No, cut my food. No, don't cut my food. Cut my food. Like, what do you, because they themselves, they don't have that ability yet. And I think it does tie into the co-regulator is, again, whether it's the parent, the therapist, or the way that we're using equine movement is they don't have that ability yet. And so we see it a lot in the schools or when we're using kind of sensory equipment. If you have like a student and the kid is like, swing me more. And then they get off and they're like, "Wah!" Because they can't self-regulate. And so that this is where the regulator piece comes in is I can only take this much. You're really asking Blackie for more. And maybe depending on where his receptive language is, think about it. What would it feel like to have more, or like whatever the more of your equine movement is? Would it be bumpy? Would it be fast around it? But we're really not doing it because he can't handle it yet. So we can let him explore it as his cognition, right? If that's a strength for him, we can explore it with his cognition. We can talk about it. And the co-regulator piece is, as we are the central rock, we are grading that equine movement, or we are the parent that's coming in saying, looks like you're having a really hard time with this. I'm going to help you get your shoes on because it seems like you're struggling with that, as we see them kind of getting ready to melt down with this kid where tactile is a primary issue. I'm, as the co-regulator, I'm going to touch it. I'm going to talk about it. I'm going to explore it. And I'm just going to watch his reaction because he's going to react to me. Like kids with that really sensitive tactile, it's like, they're not in there. I'm going to touch the hair. I'm going to touch the wet horse. I'm going to touch the grain, bran mash. And I'm going to watch, especially around, because this kid has feeding issues. I'm going to watch around his mouth and see what's going on. And I'm going to co-regulate for him. And I might say, ew, it's yucky, get it off. If that's kind of one of the things that he goes to. And then I'm going to model. Oh, let's see, we can take this wet wipe and get it off. But I'm never going to ask him to do that until he volunteers.
Gina, I might need you to do that for me because as soon as you said putting your hands in the bran mash, I was like, oh, I don't want to do that.
Don't worry, I got you. I'll co-regulate for you.
Thank you. For those who don't know, bran mash is like oatmeal. So if you don't want to stick your hand in oatmeal, you might also need Gina or Lauren in your life.
I love it. No, I love that answer. And that already has given me some ideas So I'm excited to go back and try some things with him. He's a very interesting little guy for sure. And again, I wanted to just another, he is a kiddo that had been previously evaluated for occupational therapy with more of a fine motor emphasis and didn't qualify. He aced, everything on the Peabody. He really didn't show any functional deficits in the areas of fine motor and, general activities of daily living, minus some of those ones that were mentioned before, feeding and toileting and stuff. And so we had to take a second look, because when these feeding concerns started arising, I was like, I feel like I need an OT's input here from the sensory perspective. And so that's when the OT really started looking in more in depth about the fine motor, or the sensory aspects, and was like, oh, this paints a whole different picture. But it was wonderful. It just another example of how, even as an SLP, I have, you have to look at the whole child. You can't just look at the mouth.
I have a question for you, Nita, and a comment for Gina. Thank you, Gina. I love that description of co-regulation. That was beautiful. And then Nita, I just had a question. So when you were increasing the proprioceptive input, were you also increasing the vestibular input? Because sometimes when you increase the vestibular input, you do get more dysregulation. So that's something that we have to be super careful with. And I would love to see also increase proprioceptive input off the horse and see how he responds to that. But also, I would love that description, like maybe you describing what's going on. I think that that's such an excellent strategy.
Yeah. So when I say we manipulated the movement, we had him on a horse who has a very nice controlled jog trot. And so and that was a consideration I had, was that, okay, we're not only increasing the proprioceptive aspect, we're also increasing the vestibular aspect. And those two systems, I know as an SLP, work. I mean, we talk about them separately, but they really aren't separate. They really work and rely on each other. And so I hypothesized afterwards that it was probably the vestibular aspect that threw him off. And so therefore my sort of next go-to is, okay, maybe we try, during the equine movement piece, we have them wear a weighted vest or a weighted scarf or a weighted, blanket over his lap, try to increase maybe some of the proprioceptive aspects without the vestibular piece, since that's the part that I'm questioning maybe he was a little bit less tolerant of.
Mm-hmm. Or what about having your horse walk over poles?
Oh, that's a good one.
Instead of doing a jog, just have them go over poles at a walk. So they're picking their hooves up a little more and putting them down a little harder, and but you're not getting quite as much vestibular input.
Sure.
Do you guys have any weighted stuffed animals?
Oh,
we don't, but I love that idea.
Yeah, something that is outside of him.
Yeah, I love that. We have weighted NDT dolls. Does that count?
Mm-hmm.
It could be his buddy.
Yep.
I love it. Oh, I'm gonna plug that away too.
Which is my OT thing. I want him to dress the doll to get it ready to go on the horse with him. And so that's like, I'm thinking like, oh, I can get my dressing goal in there. And then he dresses the doll, and then the doll gets to come with him on like this outside adventure. Yeah. So there's my treatment session. I'm done.
I love it.
Perfect.
Yeah.
Well, I want to thank you both so much for taking the time to come on the live connection today. I would say that, we're getting some really great feedback in the chat that people really enjoyed your clinical reasoning and loved that idea. So thank you all so much for participating in the chat, those of you who did. And I feel like this was a very successful first coffee and case studies installment of the live connection.
Yes, we're
gonna come on and ask you speech questions.
Yeah.
We are the hosts. We do not answer the questions.
Well, again, thank you so much for joining us today. Heather, we missed you, but we hope you feel better. And we just so appreciate you guys jumping on and helping us with this. It's about time for us to sign off. So we hope everyone has a great rest of their day. And until next time, everybody, stay connected.
Bye. Thank you.